Hello, my name is Emily Freeman, and I'm a PGY4 resident at Cleveland Clinic Akron General. Today I'll be presenting my research project titled Intention versus Uptake, Long-Acting Reversible Contraception Among Postpartum Women in a Federally Qualified Health Center. I have no disclosures. It has long been known that access to full-spectrum contraception, specifically long-acting reversible contraceptive methods, is critical for preventing pregnancy as well as preventing short-interval pregnancies. The antepartum period serves as an excellent opportunity for discussions about postpartum contraceptive plans. Despite serving a population at high risk for unintended pregnancies, federally qualified health centers often have limited access to LARC on site and at their associated hospitals, which may impact contraceptive utilization. The primary objective of our study was to determine the percentage of women who followed at our FQHC who verbalized a desire for postpartum LARC during their antenatal care who actually received it within the first 6 months postpartum. Secondary objectives included determining the percentage of gravid women who had a documented contraceptive discussion prior to delivery, identifying the preferred method of contraception expressed by women, determining the percentage of women who returned for at least one postpartum visit, and finally to identify demographic variables that may be associated with women's uptake of LARC. We conducted a retrospective chart review of all women seen for antenatal care at a single resident-run FQHC from July 1, 2014 until June 30, 2017. At the time of our study, the FQHC offered intrauterine devices, however, it did not offer the contraceptive implant. Additionally, the associated hospital did not offer immediate postpartum LARC. Women aged 18 to 40 and whom delivered at the associated hospital were included in our study. Statistical analysis was performed using SPSS. Continuous variables reported as mean with standard deviations, and nominal variables were reported as frequencies with percentages. 560 women were identified in our study period. Table 1 demonstrates demographic information obtained from our sample. The majority of the women in the study were African American, accounting for 48.8% of the study population, followed by Caucasian women comprising 35.6% of the sample. 65% of the women in the sample were unemployed, and the majority of the women in the study received publicly funded health insurance, with 89% of the sample receiving Medicaid benefits. Table 2 demonstrates additional demographic variables. The average age of women in the study was 25.5. The mean number of pregnancies for our sample was 2.9, and the mean parity was 1.3. No statistically significant associations were identified between demographic variables and LARC uptake. 338 women, or 60.5% of the sample, had at least one postpartum visit. This is consistent with the national average of around 60% postpartum follow-up. 364 women, which accounted for 65% of the sample, had documentation of a contraceptive plan prior to delivery. Figure 1 is a breakdown of the contraceptive choices chosen by the women in this study. As demonstrated, 27% of women expressed a desire for LARC in their antenatal contraceptive discussions. 21% indicated a plan for oral contraceptive pills, 21% indicated a plan for sterilization, 18% indicated a plan for Depo-Provera, 8% were classified as other, 3% indicated condoms, and 2% indicated abstinence only. Of the women that desired LARC for postpartum contraception, 58% of women expressed a desire for intrauterine device. 42% of women expressed a desire for the contraceptive implant. Figure 2 shows a breakdown of LARC intention versus uptake. As demonstrated, of the 58% of women who intended to have an IUD for postpartum contraception, only 21% of women had the IUD placed within 6 months postpartum. Of the 42% of women who intended to have the contraceptive implant placed, no women were able to have this placed postpartum. To reiterate the findings of our primary objective, despite the majority of women in our study intending to have a LARC placed postpartum, only 21% were able to achieve this within 6 months postpartum. All of the IUDs that were placed postpartum were inserted at the FQHC. No women who intended to have the contraceptive implant placed postpartum received the implant. Of note, 2 women who intended to receive another form of contraception received the contraceptive implant at an outside facility. In conclusion, our data suggests that when LARC options are not readily available, postpartum uptake is poor regardless of intention. We had a postpartum follow-up rate of 60.5%, which is consistent with the national average, yet only 21% of patients who intended to receive LARC had it placed within 6 months postpartum. Barriers to LARC identified in our study include cost of stocking devices, insurance reimbursement at FQHCs, and not providing options for LARC placement during the postpartum visit. Strategies need to be developed to improve access to LARC methods, including expanding LARC options at FQHCs, including same-day placement, expanding immediate postpartum services, improving antepartum contraceptive counseling, and improving reimbursement and insurance coverage at FQHCs. I would like to thank my co-authors, Dr. Cassandra Heiselman, Madeline Newbosch, Dr. Connie Cottrell, and Dr. Stephen Basic for their support and work on this project. Here are my citations. Thank you for the opportunity to present my research.